So we can start. The first presentation is by Ashish. Ashish, please go ahead. We'll stop our sharing and you go ahead. Rupesh, you are here, so let's listen and let's
Yes, sir.
try to have a good discussion out of it.
Yes,
Ashish,
sir.
on to
Yes.
you.
Yes, sir. Thank you, sir. A warm good morning to everyone. My name is Ashish Jaikishan. I'm going to present a case which is a double mini crush, and there have been few issues because of which we'll just talk about why the imaging was done the way that we did over here. So this was a 62-year-old male gentleman who had turned up with complaints of exertional angina since last 1.5 months. On his normal echo, we found that his
Ashish, can you increase your volume little bit?
yes,
Your
sir.
voice
Just
is
one second.
little low.
So we have this
Yes.
patient who has been having history of exertional angina since last 1.5 months. On his evaluation, we found that he had a normal LVF. He also had underwent a stress echo test, which turned out to be positive. He was being taken for an angiogram, and this is what his angiogram had revealed. The right system, which I'm not showing, was a non-dominant one, and then the left system is this how it looked like. A small circ, but a very large dominant ramus, and a branch of ramus also contributing to a larger area was also having a lesion. So these were the two lesions on the ramus as well as its side branch. What we can also appreciate is that his LED was also being afflicted with a stenosis of nearly 99% with a 21 flow in LED territory that is turned up over here. In an yellow caudal view, this is what we could see, and you can appreciate that the ramus is in turn actually a huge vessel. And definitely, we can also analyze and see that the distal left main is also afflicted in this particular scenario. So our idea was that yes, he would require treatment and intervention, and he was given an option for CABG in this scenario because the patient was diabetic also, but the patient had refused. So we thought that let's take him up for a for a plasty. Now to address distal left main LAD ramus, a large ramus, and with its large branch, definitely it turns out to be a complex bifurcation. Why so? Because it did fulfill our major and a minor criteria, in which one of the major criteria, that is the left main bifurcation with a side branch more than 10 mm and side branch diameter stenosis being more than 70%, and the minor criteria where there were multiple lesions and an angle which was less than 45, where the minimal reference diameter was less than 2.5 and the length was more than 25 mm. So all of these criteria were fulfilling, and so we had to label him as a complex bifurcation lesion. Now, when we talk about complex bifurcations, the things that we are comfortable, I would my mentors and my teachers have already told me, and we also try to follow it. Try to master one of the techniques and be the best in that. So over here, the idea was to obviously definitely to address the bifurcation lesions. The ways that we can go about would be a classic crush, which could be with first kissing, it could be a mini crush, it could be a DK crush, it could be a nano crush. So whichever way you are comfortable, that's what our teachers taught us. So this is what we went ahead and did. This was the mini crush technique that we have used in this scenario. The idea was to secure all the branches. First, we tried to secure the LED. Once the LED was being secured, then we went ahead and tried to secure the ramus as well as the branch of ramus. So all the three were being wired, and this is how it looked like after the wiring was being done. Now, our technique which we were using, as we just talked about in the first slide, that it was a double mini crush. We wanted to address the ramus and its branch first, and then come to LED and the left main together with that. So this is how we went about. After doing an adequate pre-dilatation of the ramus branch as well as the ramus, we had taken the stents, and the stents was that we were using were 2.25 by 28 in this branch, and the main ramus was having 2.75 by 22. First the dilatation of the side branch, and then it was being crushed with the main branch. So the challenges that we generally tend to see while doing these bifurcations are definitely, we all know about the plaque shift, about the rewiring, and how we are accessing these side branches. So we ensure that all these areas that we should not flounder, and because of that we were able to achieve a good result in the side branch as well as the main branch with respect to ramus. So this is how the side branch was being crushed by the main stent. Once that was being done, this is how it had looked like. We did a pot, rewired the side branch. Once the side branch was being rewired, then we did the kissing of both the branches of both the vessels, and this is how it looked like. So once we have fixed our ramus followed by the side branch of the ramus, we then moved on towards our LED. But before doing that, we wanted to see how our ramus looked like. So we did a piece, we did a OCT of the ramus with an adequate MSA which has been achieved, no significant dissection on either of the edges. This was the OCT revelations. So after unfortunately, we just had this one run through of the main ramus. We couldn't do the side branch ramus OCT. So I'm just showing this one over here. The adequate dimensions were being documented. The MSAs were being documented over here in the ramus. Now, how about LED? Well, the idea was that yes, definitely we needed to fix LED, and the LED was being turned as a side branch, and left main to Ramus was being considered as the main branch, and this is how we had gone about. After making an adequate pre-dilatation for LED, we then took the stent, which was 2.5 by 38 in LED, and left main to Ramus was 3.5 by 12. This is how we had gone by. After LED was being deployed, then we had crushed it with the with the main vessel, that is left main to ramus. After the ramus stent was being deployed, left main to ramus was being deployed. We then took out the wire and we did the pot. Once the pot was being done by the left main to ramus, we then rewired our LED. After the rewiring, we did the final kissing of this. Once the final kissing was being done, again the report was being done by 4 by 8 in left main itself. This is the final OCT that we had achieved, which was from first we did from the ramus to left main. So what we can see over here is that there is the two struts that have been coming up of the ramus as well as left main to ramus. This is the one, and you can see the side branch, that is the LED, could be also seen. It is an adequate, well opposed stem. This is from ramus to left main. We had achieved an adequate MSAs over here also, no dissections on either of the edges. And then finally we did a LED to left main OCT run. Again, what we can see is that there were no dissections, MSAs were appropriate. Even at the level of this bifurcation, what you can see over here, coming over here, it's an appropriate deployment. The left main was adequately opposed and MSAs were appropriate over here too. So this was a final analysis that we had from our LED to left main also. The final shot that we had taken is this one, sir. All the branches running smoothly and no dissections on an angiogram. So with that, I would like to thank you all, sir.
Thanks, Ashish. This was a beautiful case. Let's go to Rupesh first. Rupesh.
Yes, sir. Yeah, right, sir. Perfectly done. Double bifurcation. Uh, so I also like for bifurcations. From the time of our training, we have always been doing mini crush. Somehow DK crush was never popular in Yun Mehta, so I never actually moved on to DK crush. Like Ashish pointed out, we learned one technique well. So we have always been doing mini crush since we started doing bifurcations. Only thing that I do differently is once, like before crushing the side branch stent, I would probably take that wire out. Sometimes we have seen those entrapment. I see that in both the times during crushing, you did not take the wire out. Uh, I mean, it comes out most of the times, but then there are times when it might, get entrapped because it's between two metal
Oh,
layers.
yes, yes.
Otherwise, almost a perfectly done case and as OCT demonstrated clearly, it has been opposed. All the osteums are nicely opened. So all marks to you.
No, I think rightly said by Rupesh. I also noticed that wires were still stagnant, and you were lucky that it came out easily. But at times, since it is now sandwiched between the two metal layers, it may
Yes.
get stuck, and you may have a lot of difficulties. So that is one thing. Second, I mean, here it looks like a reason why you chose to make a main channel from left main to Ramus rather than left main to LED. But we all know LED is LED. If the LED is not infarcted, that is the best, most important vessel. So at times, one may take this decision based on the caliber of vessels, which here also looked like that Ramus was bigger than LED. But that also is a scenario that, LED was a deprived vessel. It had a more significant, more critical lesion. So rather, at some point, if we pre-dilate, give lot of nitro, wait for some time, and you have done a OCT, you had a OCT in hand, just see the caliber of LED, how much, if it is matching left main, I think it's always as a rule, one should go with left main to LED if the caliber difference is not very big, So,
Right.
but at rarely, I have also done that, taking a left main to circumflex as the main channel and mini crushing the LED ostium. But what I'm trying to say, the mini crush point is more uh, predisposed for restenosis. So, and LED osteal restenosis will give more symptoms rather than a ramus restenosis. From that angle, always think and try to make left main to LED as a main channel.
Main vessel. Agreed, sir.
Yeah. So
Sir,
good, Ashish.
just one question, like what are yours take like for this double bifurcation cases, especially now with DCB catching up? What about hybrid DCB, like you do a DCB in one of the side branches?
So the
Probably
idea,
not the LED. I would never leave the LED alone, but
the Ramus
probably
branch
one of
is,
the Ramus branches
yes.
could have been done with a
That
DCB.
was a possibility that we had thought. So there were two issues with us on that day in our lab. We didn't have an IVUS support because for left main usually we require an IVUS. Unfortunately, IVUS was not working, and with the DCB we didn't have DCB in our shelf of this size. So that was the reason we decided let's go for stenting rather than leaving it or just doing a plain POBA would also not have served the purpose. That's the reason why we had switched on to stenting of Ramus branch.
Right, Ashish, full marks. Full marks. This was a
Thank
tough
you.
case and you managed it quite well.
Thank you very much, sir. Thank you,
And
sir.
we keep giving us more tips about stock market.
Definitely,
Okay.
sir.
Okay.
Definitely.